So given the data that's available for the use of CDK4/6 inhibitors in metastatic hormone receptor positive disease, I think this class of agents is really something that can be applied uniformly to all patients with metastatic hormone receptor positive breast cancer at any point in their disease course. That we have 3 agents that are currently FDA approved, and all 3 of these agents have an approval either in the first or second line setting in combination with endocrine therapy. And we have one of these agents, abemaciclib, which also has an approval as monotherapy in a patient who has progressed on prior chemotherapy. So I think given these 3 different agents with different approvals, again, they can be used in combination with endocrine therapy upfront or even as monotherapy in a late line setting if someone hasn't seen a CDK4/6 inhibitor to date. I think it's also important to realize that these agents can be used in both pre- and postmenopausal patients. So we've seen data from the Mona Lisa 7 study, which was specifically for premenopausal patients, which demonstrated that adding ribociclib to endocrine therapy had a very impressive improvement in progression-free survival, which is similar to what we've seen in the other randomized trials in postmenopausal patients, again suggesting that these agents have benefit also in the premenopausal population, which is certainly also supported by the subgroup analyses from Paloma 3 and Monarch 2. So I think really these agents are applicable across a broad set of patients with metastatic hormone receptor positive breast cancer. There are 3 CDK4/6 inhibitors that are currently FDA approved. There's palbociclib, ribociclib, and abemaciclib. And I think there are some slight differences between the 3 agents. So we do know that palbociclib and ribociclib both hit CDK4 and 6, but they do so fairly similarly. So for example, palbociclib hits CDK4 as well as it hits CDK6, whereas abemaciclib is much more potent against CDK4 than it is against CDK6. So I think biologically these drugs are slightly different. We also know that the drugs are dosed differently. So for example, both palbociclib and ribociclib are dosed on a 3-week on followed by 1 week off schedule, as opposed to abemaciclib, which is dosed twice daily, but then also dosed continuously. So I think scheduling is also a little different. And this is in part due to toxicity differences. So we know that both palbociclib and ribociclib are associated with about a 60% rate of grade 3/4 neutropenia, which is different than abemaciclib, which has about a 20% rate of grade 3/4 neutropenia. And so while palbo and ribo have more neutropenia, abemaciclib has more GI toxicity. So we do know that about 9 to 10% of patients getting abemaciclib can experience grade 3 or 4 diarrhea. So again, the scheduling is a little different. Their toxicities profiles are a little different. And biologically, their potency versus CDK4 and 6 are slightly different. So I think the CDK4/6 inhibitors have certainly significant benefits for our patients. We do know that when you add a CDK4/6 inhibitor onto endocrine therapy in the first or second line setting, there's a dramatic improvement in progression-free survival. So regardless of which agent you choose, whether it's palbociclib, ribociclib, or abemaciclib, in the first line setting, the hazard ratios are really almost the same. They're around 0.55, regardless of which agent you're using. And then recently, we've seen data to suggest even that adding a CDK4/6 inhibitor in the second line setting is actually associated with an overall survival benefit. So data from Paloma 3 demonstrated that within the endocrine sensitive subgroup of that trial, that there was about a 10-month improvement in survival, which I think is quite striking. So I think overall these agents do have significant benefits to our patient population. But I think there are some challenges. This is a patient population that we used to just give endocrine therapy alone to. So these are patients that we would only have to see in clinic every few months, and they weren't experiencing lots of toxicities. They didn't require a lot of monitoring. And so adding on an agent certainly does have implications because it does add toxicity and it does require monitoring. So from a patient quality of life, I think it does have some implications.
On the other hand, in the second line setting, I think some of those patients may be facing being offered chemotherapy, and so they're certainly happy to know that there's something aside from IV chemotherapy that they may have the option to take. And although there is more toxicity and more management, at least up front, it seems most people have heard about these drugs and are excited about them and feel grateful for the opportunity to have access to them.